Thank you, Susan. And as a patient advocate, I want to commend Heather for her advocacy, her work. It's what it's all about when you're a patient advocacy, so tremendous work there. I also want to thank the Secretary for convening this meeting with all the stakeholders. It's really the National Health Council way. Our organization is controlled in terms of its governance by the CEOs of the patient advocacy organizations. We have all stakeholders in membership, and that includes providers, payers, and the biopharmaceutical sector, device sector, and soon the Generics Association. We work to achieve solutions to very complex situations that are patient-centered, but involve all stakeholders so that we can truly make these solutions work. And this is the only approach where we can address this issue. I wanted to talk to you about three specific issues in my opening comments. First is, over the course of the last several decades, we've done research on people with chronic disease and their family caregivers. And what they tell us routinely is they hate the fact that there are industries, both insurance companies and the biopharmaceutical sector, that make money off the development of treatments or providing care to them. But they also understand that it drives innovation for the development of new treatments and for better care. More recently, our research has shifted, and the tone has begun to focus in on how plans are structured. And increasingly what we're finding for people with chronic conditions is that they're going into insurance products that have taken what was one of the greatest benefits in the Affordable Care Act, the maximum out-of-pocket cost, and they've turned it into a weapon by front-loading those costs, so that for many people with chronic conditions, they find that they hit their maximum out-of-pocket cost in that first month or two, sometimes even before they get their first medication or are able to see their specialist. That can, for many people, and on average, amount to 20% of their annual income. It's an effective bar, and it discriminates against people with chronic conditions that are of low social economic status. And people with chronic conditions are getting really angry about that. The second point I'd like to make is that finding a solution to this will not be easy. But as we heard from the previous speakers, it starts by identifying value and looking at value from the perspective of people with chronic disease. We cannot simply address the cost of one item without looking at the entire healthcare ecosystem. Medicines are a hugely important part for all people in the system, but we have to look at the entire ecosystem and collectively decide what is value and how are we going to promote value. And we certainly cannot define value without the patient perspective. And that leads me to my third and final point, and that is this. We continually conflate consumers and patients. And I'm here to say that while we are part of the same stakeholder community, we are on opposite ends of the spectrum. Consumers go into the healthcare system and they use it as needed, typically for an acute care incident. They go home to their family, their jobs, and their lives as if nothing happened. When you're diagnosed with a disease for which there is no effective treatment, or one that is deadly, or have a child who will wither and die before their 18th birthday, you have an entirely different perspective on what value is and what innovation is. We have to include that perspective with all the other perspectives when we work through these complicated issues. Thank you. Well, there are two issues that we're conflating here. So let me address that question. I also want to go back to your point about us all agreeing on the cost of drugs being the primary issue, because that's not the number one issue for the patient community. With respect to people with chronic conditions, what they'll tell you is they don't like the fact that they're paying so much out of pocket to get their drugs, but to also see their doctors, to see their specialists, to access their care. And I think what you're hearing from us, there's a lot of agreement that plan design is not working, especially for people with high-cost treatments. Now, I also want to recognize that we've created a set of incentives that compel plans to compete on trying to keep high-cost individuals out of their plans. We have not made the rules of the road granular enough so that plans can compete on value. And I think that's part of what needs to be looked at here. And there's a lot of opportunity. If you look at what happened in the co-ops in the Affordable Care Act, a lot of them are going out of business. And it's because they tried to provide really good benefits, but the risk adjustment did not work. There's opportunities to realign policies so that access can be made affordable and we can have plans compete on value. That's a critically important issue. Now, when we speak with patients, they'll often tell you that the cost is number one and they don't like the price of the drugs. Very few of them actually understand what the price of the drug was that went to the plan where they got it. They don't have that information. What they really mean is, I want access to that drug. Those are two very different elements. The other point I wanted to make, and again, going back to your earlier comment, for those people who have treatments, access is a huge issue in the marketplace and in most insurance products now, especially if you are of a lower socioeconomic status, and increasingly, even if you're just middle income. But you have to recognize, I'm going to channel one of my board members, Margaret, who's the head of Faster Cures, who said at a 21st century roundtable, we have between 7,000 and 9,000 diseases. Only 500 have effective treatments. For the vast majority of people with chronic conditions, they want a treatment, or they want the treatments that they have to get better. That's their number one priority, and for a lot of them, they would love to have an expensive option. We're now at the point where science is moving to a place where we're developing treatments that we've never seen before. It was pointed out before. We have the first specialty product that's a cure. There's huge opportunities, and for people with chronic condition, that is a priority. How we make them affordable is also a priority. But we have to look at the entire healthcare ecosystem and figure out as a society, are we going to pay for new innovation? And how are we going to make that accessible to all, not just the wealthy?
Well, and that takes us right back to you, Heather, because as you said quite powerfully, you hope that there are new drugs coming out that will continue your survival, to enable your survival. And as we heard from Doug Long earlier, the vast majority of cancer treatments going forward are going to be these targeted therapies. They're going to have high price tags attached to them, almost assuredly. How do we balance this desire, we all share it, for innovative, value-driven drugs that will extend lives, but also have them be affordable?
You're asking me that.
Yeah. You're here.
Right. First of all, I'm not on a targeted therapy. I wish I was. I look forward to hopefully being around to be on one day. But I do understand the balance that's needed. And I look at it as, I'm not sure that every drug that we have to have access to every single drug. This is from a patient perspective. I'm not sure that we need to have access to every single drug out there, which is what Americans seem to want. We want the drug that'll keep us alive 2 more weeks. I'm okay with not having that personally. That's my personal opinion. I want to see that the field moves forward, and that if we're balancing affordability with access, that we have to have some give on the access side. So I'm willing to give that up in order to make treatment more affordable. That's from my personal perspective.
Do you think most patient groups are there on that point?
And so this is the first time I've met Heather, and I'm really enjoying listening to you speak. From the patient perspective, one of the issues we're looking at is exactly that. The presenters earlier today said there's $220 billion in low-value or no-value service, and in some cases, services that actually increase cost by creating other complications. For people with chronic conditions, we often say they want access to everything. Well, the reality is they don't want access to everything. What they want is access for what works for them. And that requires us to move away from just treating people as the average because nobody is the average. Most people have multiple chronic conditions. We have to look at how we drive treatments for that 20% that drive 70% of the cost, or that 5% that drive 40 to 50% of the cost, and build a system that is different. We need to be able to look at those people and say, we're going to spend the time with you to understand what is going on in your personal life. What are your goals and aspirations? And then we look at the clinical options that are available, and we help them match the right options for the right person. And that often means less care, less invasive care, and there's great research that shows that you reduce costs and you improve outcomes. And in fact, when you look at individuals, take two individuals with Parkinson's. They're at the same stage of disease progression. They're both working. One person wants to ensure that nobody knows they have Parkinson's. The other person wants to eliminate the tremors that are keeping him awake and impacting his life with his spouse. Those are two entirely different options, and it requires two different treatments. And yet our current system will give you the average, and you may not get the one that's right for you. When you align the treatment with the personal circumstances and the goals of the individual, you'll often see less care, and it's often better care, and we have an opportunity to save money. So looking at how we get at value in the system and how we align incentives to drive value. And I'm all for incentivizing plans to do this, and I'm all for incentivizing biopharmaceutical companies to develop high-value treatments. We have to look at how we balance that. CMMI is doing this great project in Chicago where they're actually paying doctors to spend 90 or 120 minutes with high-touch patients that are high cost, and actually align their care and coordinate it and eliminate the unnecessary waste. And what they're finding is they're reducing costs and they're getting much better outcomes. Now, we don't all need that, but for that 5 or 20% of the population that are driving the cost, we do. And that creates room for high innovation that is going to have some cost. I think we have to recognize there's going to be some cost, but we have to make it affordable, and we have to make sure it happens, because there are tens of millions of people in this country that are dying as a result of their diseases, and they want new and better treatments. You're absolutely right, Carl. It is fundamentally discriminating against people with chronic conditions, in particular those of low socioeconomic status. I think we have to recognize that, but I think we also have to recognize that the plans have been put into place with rules that are not granular enough for them to compete on value. So we have to work with the plans to actually help them solve the problem that they are in order to eliminate these issues. I completely support spreading out the costs of out-of-pocket costs across months, putting caps on out-of-pocket costs. But at the end of the day, it's going to create pressure to create other mechanisms that get at this. We've got to figure out a way to work with the plans to figure out how we can set the rules of the road so that they can compete on value rather than on excluding high-cost patients. I would put it in this context. So we did analysis when the marketplaces opened up. And one of the very specific examples we did was a woman in the District of Columbia who had heart disease and she had rheumatoid arthritis. She was working above minimum wage full-time, eligible for cost subsidies for her premium, and if she got to the right silver plan, which is very challenging for a lot of people because they don't understand that, but if she got to the right silver plan, she was also eligible for subsidies in her out-of-pocket costs. For that individual, she was going to pay almost 20% of her annual income in out-of-pocket costs over the course of the year. And depending on the plan she selected, it might be in the first 2 months of the plan. So I completely agree with you. I think the cost-sharing mechanisms are not working as effectively as we would like. I also agree with you that if she had hepatitis C and was receiving that drug, the insurance company would have picked up a substantial part of that cost. And I'm not here to say that the plans are doing anything wrong. What I said earlier, and I completely stand by this, the plans are acting completely rationally within the rules of the game. What I think we need to do is work with you to alleviate some of the pressures that are on the plans so that they can provide affordable coverage that is not impacted by socioeconomic status, that really allows you to compete on value. I know a lot of plans want to do that. We had 2 chief medical officers from 2 of the largest plans in the country nominate themselves to be on our board because they want to work with us on these issues. And I want to work with you on these issues as well.
Of course, the broader point is that we do waste a lot of money elsewhere in the healthcare system, and if we could, and we also impose costs on consumers because of that, if we were to gain some of that money back, we could potentially afford to spend money on some of these very innovative treatments that are in the pipeline, as we heard earlier. Mark, how do your members approach that larger question?
Well, and that's one of the points I tried to make at the beginning, and Alan, I think you're absolutely correct. We have to look at the entire health ecosystem. We tend to think of the innovation ecosystem as separate, and then the delivery system is something else. But the reality is it's all intertwined. And from a patient perspective, it's a cumulative cost that ultimately prevent many people from actually getting care. You know, one of the questions we talked about as a group is, what is the impact on the family budget? Well, for a lot of people of lower socioeconomic status, there is no impact on the budget because they never fill that first prescription. They never see that specialist. That is not acceptable. We have to look at the entire system, and then we have to define what value is, and then we have to go and create the incentives and levers to drive value. In many cases, that's going to be high-value products. It may be high-value surgical interventions. It may be high-touch delivery designs where you really help those people with complex chronic conditions who are falling through the cracks, not getting the services they need. If we simply look at each issue in isolation, we're leaving a lot of the opportunity on the table. And I go back to something I said earlier. All the estimates are that there's $220 billion in waste. The vast majority of that is spent on that 30% of the population we represent, people with chronic disease and disabilities, by providing them care that is completely unaligned with their personal circumstances and their goals and aspirations. There's huge opportunities to drive waste down if we think about this different. There's huge opportunities to drive high-value interventions, and there's also opportunity to drive costs down. But we have to look at it as a package.